This is the sepsis form. Sepsis form is this is one of the stations in RCSI exam. It's a very important station. In this station, you might get the definition of sepsis, signs and symptoms of sepsis, and they will give you one scenario. In that scenario, you might get that the patient might have with the immunocompromised patient, that is HIV patients, and the patients with the high temperature, and the patients will have conditions like I can say that condition with the chronic lung disease, that is COPD. So they will ask you, why would you think this patients need sepsis form? Then you have to answer that in the case of pneumonia or the COPD, we think that might be the cause for sepsis because there is unlikely for having an infection. So we are going to the next step, that will be INU score, that will be more than 4, and if it is more than 5 with on oxygen, INU score is less than 4 or less than 5 if on oxygen immunocompromised or older person. If there might be an scenario, the patient's age will be more than 75, an older person, and ED sepsis screening at triage. That is the one more causes. If these two things are there, then you will go to clinical judgment. That is 1, 2, 3. Uh, you can see the bulb here. Here in the bulb, this is one of the bulb. So you will go to the next step, that is risk for neutropenia, and the next one is clinical evidence of new onset of dysfunction and systemic inflammatory response. You will check these three things. In these three things, there is an explanation in the other page. So I'm going to tell you about this next page, which is having the explanations. So the infection sites that might be likely, earlier I told you there is an infection site. So the infection site that might be an respiratory infection, central nervous system, catheter device, intra-articular bone or skin, intra-abdominal or urinary tract, or unknown. So we have checked there is a three type of infection that might cause or that might to start the sepsis form as well. First one is the risk of neutropenia. Risk of neutropenia, patients at risk of neutropenia due to bone marrow autoimmune disorder. The conditions like SLE, and the patients with having HIV, and patients with the cancers with the having chemotherapy or radiotherapy who presents unwell. In this condition, you will be having one of this criteria, and second one is clinical evidence of new onset of organ dysfunction. If one of this following, and that might be the cause to start this form. And third one is systemic inflammatory response, that is there will be two or more than two SIRS criteria plus one comorbidity. So you have to note physiological changes should be sustained, not transient. That means if the patient's respiratory rate, it should be in a same rate. It should not go to normal within 2 or 3 minutes. If it is same rate, that in that time you can use this criteria. You can see here there is a respiratory rate of more than 20. If this respiratory rate more than 20, if it goes back to 18 within 2 or 3 minutes, then this criteria will not be will not be taken. So heart rate also, if it is more than 90 beats per minute, this is one of the criteria, and it should be sustained, but not transient. Means it should be this in this level. It should not go down from this. Then it will not be. If they are asking you on questions on this, then you have to tell it should be transient. It should be sustained but not transient. Then white cell count, that should be more than 4 or more than 12, and temperature is less than 36 or 38.3, and acute altered mental status and bedside glucose 7.7 mmol per liter in the absence of diabetes mellitus. If the patient doesn't have diabetes but his glucose is more than 7.7 mmol, this is not the patients with the diabetes mellitus, this is without diabetes. If their glucose levels goes more than 7.7 mmol per liter, then comorbidities associated with increased mortality in sepsis, that will be COPD, DM, frailty, HIV/AIDS, age more than 75 years. Most of the time they are giving the age in the scenario. So just make sure, keep in the mind that this is one of the comorbidity. And recent surgery or major trauma, immunosuppressant medications, chronic liver disease, cancer or chronic kidney disease. If these of the criteria, if this is the one of the following criteria with infection, then you will go to the next step. The next step will be, um, if there is an evidence of 1, 2, or 3, or if an inpatient use INEWS escalation and response protocol, in that you have to escalate to medical review within 30 minutes, and the medical review should happen within 30 minutes, and the ED triage category will be 2. Then you will write the name, DOB, HCRN number, and date, and INEWS, and signature, and NMBI pin, and the triage category. So once the medical review happens, medical review done by the physician. This will not be filled by the nurses. This is the physician. You have to mention these things. Then he will come and check the site of infection. If he thinks there is no clinical suspicious of infection, he will end the form and sign at the bottom. And if he thinks there is a site of infection, then he will check this criteria: at risk of neutropenia, new organ dysfunction, or SIRS plus 1 minus 1 comorbidity. In that case, he will tick this. If he thinks infection is present but clinical judgment are not applicable, infection is present but the clinical judgment are not applicable, in that case the treatment pathway will be different. But review diagnosis, if patients deteriorate, then he will tick here and he will sign the form. If it will go to the next step, if he thinks there is an infection and plus there is a three criteria will be followed, then you will go to the next step. In this step you will see if this patient is having an end of life care plan in place where the sepsis would not be appropriate. End of life care in the uh, in that case, the patient might have planned that patient does not require any treatment, means end of life care. So he's already going to die. So there is no point of doing, and they have an already end of life care plan in their file. So in that case, if that is end of life care plan is available, will not proceed with this plan. So we'll tick it as yes. And in that case, do not proceed with the sepsis pathway and documentation in clinical notes. So if there is no any end of life care plan, then you will go to the sepsis 6 bundle. The sepsis 6 bundle has to be continued for within 1 hour to complete. Within 1 hour, in the sense, if the sepsis bundle we started at 3 o'clock, and within that is from 3 is a time zero, the completion should be within 1 hour. It's called as an golden hour. So we have to finish sepsis 6 bundle, that is take 3 and give 3. Take 3 blood culture, blood test, urine output, that is take 3, and give 3 is the IV antimicrobial, IV fluids, and oxygen. So there is a bulb here, you have an explanation in the other page. So in the sepsis 6 bundle, you will see the blood culture. The first you have to take blood culture using aseptic technique prior to giving antimicrobial, unless this lead to delay, that is within 45 minutes. Other culture has indicated in in the scenario, if the patient have COPD, you should consider taking an sputum culture here. So please make sure that check your scenario each time whenever you are going to the next step. Think of your scenario and answer this question. So blood test point, in the blood test point of lactate, This is an important indicator to find out the sepsis. It might be venous or arterial, that is an bedside point of lactate care and full blood count, renal profile, liver profile, plus minus coagulation screening, other tests and investigations has indicated. In the urine output, this is one more the indicator. Assess urine output as part of volume perfusion status assessment for patients with sepsis shock. Start fluid balance chart. Catheterization and hourly measurement may be required. So these are three, that is blood culture, blood test and urine output is three. Take three and give three. Give three is the IV antimicrobial. In the IV antimicrobial, you will give the antimicrobial guidelines based on the site and source of infection. That is, if it is an UTI, you will think of giving nitrofurantoin, and the other thing you will based on the allergy status, and you have to assess of source control. Next one will be IV fluids. The patients with the hypertension should receive up to 30 ml per kg isotonic crystalloid within 1 hour of presentation. And in the example, like if 70 kg, 70 into 30, you will count how much is the fluid required. Then you have to start the vasopressor. If patients are not fluid unresponsive, patients with the hypoperfusion should receive fluid to restore perfusion as a bolus and review technique. In the bolus review technique, in the sense, first give 500 ml over 15 minutes, then you will reassess. Then bolus may be amended based on the clinical context. Call anesthesiology critical care if hypotensive or if unresponsive to fluids. Oxygen in if needed. In the condition with the COPD, 88 to 92 is the normal range. In this case, if the saturation is less than 88, you will consider with the chronic lung disease, we will give the oxygen. And if the patient doesn't have any chronic lung disease, then you will consider 94 to 96% is the normal range. Based on that, you will give the oxygen in case if only needed, otherwise the oxygen is not required. And next you will do, after the all the blood tests, you will do medical review, that is post sepsis 6 bundle. After take 3 give 3, you will do the post sepsis 6 bundle. You have to check again evidence of infection and a new onset of organ dysfunction, that is including of initial presentation. Uh, if it is also presenting during the initial time, then you will also consider this is an sepsis. For evidence of infection, you will check that if there is a lactate is more than 4 mmol after 30 ml per kg of intravenous fluid therapy. After giving fluid also, if lactate is increasing, that is a signs of organ dysfunction. And the cardiovascular, after giving uh, fluid also, you will, if the blood pressure is less than 90 mm of Hg, or mean arterial pressure will be less than 65 mm of Hg, or systolic BP more than 40 mm of Hg below patient's normal range. And in respiratory need for an oxygen saturation more than 90%, and renal creatinine more than 170 micromillimole, or urine output 0.5 per kg, 5 ml per kg for 2 hours despite adequate fluid restriction. Even giving fluids, the urine output is not increasing. In that case, also considered as organ dysfunction. Liver bilirubin more than 32 micromole per liter, and hematological platelets. This condition usually happens with the patients with the cancer patients or autoimmune disorders like SLEs, and central nervous systems, that is acutely altered mental status. We can check these things with the patients with the more than 75 years of age. So these are the criteria for the evidence of onset of organ dysfunction. If you think, then you will go back here, and if there is an evidence, you will say this is a sepsis, then you have to seek senior output as per local guideline. Then after that, look for sepsis, septic shock, that is require inotropes pressure to maintain MAP, that is uh, more than 65 or 65 mm of H, then you will tick here. If the map you need if the map is more than 65, to maintain it. Then you need the inotrope or pressors. Inotrope or pressors like adrenaline and noradrenaline, and evidence of organ of infections without any new onset of organ dysfunction. In this evidence of infection, but there is no organ dysfunction, then this is not sepsis. Then you have to go proceeds with the usual treatment. Then if uh, then proceed with the treatment. So this will be ticked here. So after septic shock, if you think if it is a sepsis septic shock, then you have to inform the consultant. This will come from here to here and contact the critical care. Then you have to tick here. In case if after these all things, if someone is relieving from duty, then they have to tick which and all things he has done, whether he has finished with the A or B. In that case, he will tick here and he will sign. And if the same physician is continuing, he will not fill this. He will directly fill here the name, signature, and MCRN number, date, and the time. So this is an important thing, and you can see there are some more points here. This is also important. You have to reassess patient clinical response frequently, reassess and repeat within 3 hours more frequently as indicated, and achieve source control if required at the earliest opportunity. Seek senior assistance and reassess antimicrobial therapy, and use clinical judgment. That is the sepsis form. So please keep in mind that once the scenario has been given, just use the scenario based on that, answer it. Just so this is the explanation for the sepsis form.